It's my honor to be here tonight. I want to thank Nora Kane for inviting me to speak to all of you, and I want to thank all of you for coming out on a Thursday evening to listen to me speak. Today I'm going to be talking about my book called Drug Dealer MD, and I'd like to start with just talking a little bit about the title. The title is provocative, and it's meant to be provocative so that people will read it. And it's also a little bit misleading because it implies that my book is about willfully nefarious doctors exchanging prescriptions for cash. And really what I'm trying to get at in my book is well-intended, compassionate doctors who got caught up in a system and ended up harming their patients unintentionally, and I would actually include myself in that group. My mother-in-law, who has been supportive through the process of my writing this book, said to me when I told her the title, she said, "Are you sure you want to call the book Drug Dealer MD? Won't that be offensive to your colleagues?" And, I thought about what she said, so I shopped the title around a little bit to some of my colleagues, and almost all of them had the same exact reaction, but I'll share with you what one of my colleagues said, who he's a rheumatologist, and he regularly treats people with considerable pain. I said, "Yeah, I'm calling it Drug Dealer MD," and he said, "That's me." So my point is that we are at a place in medicine where many physicians feel that we sometimes are in the role of just dispensing drugs without necessarily being in a position to help our patients the way we really want to, and that's what I want to talk about tonight. So the subtitle here is How Doctors Were Duped, Patients Got Hooked, and Why It's So Hard to Stop. I talk about all of those things in my book. How doctors were duped, the short answer is Big Pharma. How patients got hooked, the short answer is Vicodin is the same as heroin. Benzodiazepines are the same as alcohol, and stimulants prescribed for attention deficit are the same as methamphetamine or speed. So the reason patients get hooked is because these drugs are addictive. I can't cover all of that in one talk tonight, so I'm going to focus on this last part, why it's so hard to stop. I do want to say that I am deeply grateful to all of my patients who shared their stories with me, and I talk about their stories in the book. And without their personal accounts, the book wouldn't be what it is. So I just want to shout out to my patients. Thank you for letting me tell their stories in the book. So what is it that we're talking about here? We're talking about a phenomenon over the past 2 to 3 decades in which deaths in this country related to prescription opioids skyrocketed. As you can see here, between about 1999 and 2010, the number of deaths due to prescription opioids quadrupled in this country. That's the red line. But if you look in parallel, the blue line was opioid sales. So the opioid deaths increased at the same time that doctors were increasing their prescribing of opioid analgesics. And that's a really important point here. This is the first opioid epidemic in American history, which was driven primarily by doctors' prescribing habits. Today, prescription opioid deaths cause about 41,000 deaths per year, more than that caused by traffic accidents or guns or falls. It's the third most common cause of death in the country, and leading the way are deaths due specifically to opioid painkillers, which cause more than 16,000 deaths annually. But a really important piece of this story that I really want to focus on tonight is, if you look here, in 2011, the CDC declared that we were in the midst of an opioid epidemic, and they made it very clear who was primarily responsible. They said it was doctors over-prescribing certain types of addictive drugs, in particular opioid analgesics. From 2011 on, you could not open a major newspaper or listen to mainstream media without hearing something about the opioid epidemic. Even though it became a well-known phenomenon, although prescribing slightly plateaued, really there was very little change. And in 2014, There were nearly 300 million prescriptions written for opioid analgesics in this country. So the point is, even after doctors became aware of the problem, they continued to prescribe opioids excessively. That's really something that we have to look at. I had a journalist call me and say, why don't they just stop? And it's a great question, why don't they? And those are some of the things I want to look at tonight. This is a paper we published in JAMA. It's a little bit hard to see, but the main point is here, what kinds of doctors, what kinds of specialties are primarily prescribing opioids. By volume, it's family medicine and internal medicine doctors. Now, that's not to say that individual family medicine doctors prescribe the most opioids. It's to say that as a specialty by volume, because there are so many more family medicine doctors, they are responsible for the bulk of opioid prescribing. If you look at individual doctors, it's really anesthesia and pain medicine doctors, which makes sense. We would expect that someone who treats cancer would prescribe more chemotherapy than someone who doesn't. But the important point here is that across the board, we have all kinds of different specialties prescribing lots of opioids. So the question then becomes, what is driving overprescribing, since overprescribing is really at the root of this opioid epidemic? My book covers this. I can't go into all these different facets, but I'm going to quickly touch on each one. There was a huge paradigm shift within the practice of medicine around treating pain. Prior to 1980, doctors were very stingy with opioids because they were very concerned about making their patients addicted. Around 1980s, 1990s, there was a shift toward more liberal prescribing of opioids, not just for trauma or surgery or end of life, but even for common medical conditions. The reason that happened is complex, but has to do with an awareness within medicine that we weren't doing enough to treat pain, that we were leaving patients in pain, and there was a kind of a hope that maybe opioids could help with this problem. There was the infiltration of Big Pharma, or the pharmaceutical industry, promoting more opioid prescribing and basically adulterating the scientific evidence to convince doctors that the evidence supported more prescribing, when in fact today we know that opioids given long term for chronic pain conditions don't work. Let me say again, opioids don't work long-term for pain, but they are fantastic short-term for pain. So on the order of a couple of days to a couple of weeks, opioids are magical treatment for pain. The problem is if you give them long-term, the brain undergoes what's called neuroadaptation, such that they simply don't solve the problem of pain anymore and can even render the patient hypersensitive to pain. Nonetheless, there was this shift within medicine influenced by Big Pharma and also some cultural changes around our conceptions of pain in general and how much pain our patients should be able to tolerate. And I talk all about that in my book. The other kind of factors that contributed to overprescribing have to do with what I call the Toyotaization of medicine. You can't see that very well, but it's supposed to be an assembly line in a Toyota factory. The fact that as more and more doctors moved out of private practice and into salaried positions in large integrated healthcare systems, they had less and less time to see patients. They were reviewed by patients in terms of how much their patients liked them, so there was more pressure to be liked. Some primary care physicians now see up to 40 patients in a single day with less than 5 minutes to address multiple complex medical problems. Sometimes it's all you can do to just write the prescription and move them on. There are also issues related to disability and how disability has encouraged more opioid taking and opioid prescribing. Issues with insurance, where insurance won't cover non-opioid alternatives, a huge issue. Insurance also typically won't cover addiction treatment, another big problem. And then, of course, Big Pharma, which I've talked about. One of the aspects that's continuing to drive this phenomenon of overprescribing is actually a very intimate relationship between the doctor and the patient when it comes to exchanging that prescription for opioids or other addictive controlled drugs. And that's what I'm going to focus on in my limited time in the talk today. So first of all, when we try to understand what's going on between doctor and patient around drug seeking, and by drug seeking I mean the patient who begins to become addicted to the medication that their doctor is prescribing. Maybe somebody with pain who went in for pain treatment, got a prescription for OxyContin or Vicodin. It initially helps, but then somewhere along the way, that patient begins to develop addiction to that drug and finds themselves maybe going in and asking for more drugs from their doctor, or maybe going to multiple doctors and getting the same drug. This is what we have to understand. What is motivating this kind of patient? So what I'm going to do next is I'm going to talk about, so in a way I was sort of the anthropologist in the white coat as I was writing this book. I did a lot of observing of my patients and observing of other colleagues' patients and talking to patients and doctors. What are some of the techniques that patients who are drug seeking use to get prescriptions from their doctors? And I think it's very revealing, but I want to say that these kinds of descriptions that I'm going to use are not intended to make light of the condition. As I'll talk about shortly, the drug-seeking phenomenon is really largely driven by the phenomenon of addiction, which we do conceptualize as a disease, and I'll get to that next. First, though, let's look at some of the techniques that drug-seeking patients use to get the prescriptions that they want from their doctor. There's the filibuster technique. This is when patients wait to the last 30 seconds of their time with the doctor to ask for a refill, because they know that for the doctor to say yes to that refill will take about 30 seconds, but to say no would add another 30 minutes to their schedule. So sometimes the doctor will just refill the prescription in order to move that patient along. There's the flattering technique, very common, where patients tell the doctor, "You're so wonderful, you're so much better than my other doctors," and the doctor wants to reward that. They feel good about themselves. "I'm a good doctor. This patient likes me." They give them the prescription. Demonstrating pain behaviors is very common. I've had patients who are writhing on the ground, all kinds of expressions of pain. Many of these people have real pain, but they demonstrate their pain to the doctor in order to communicate how desperately they need that drug. Teaming up is very common. Patients coming in with typically their mother is a phenomenon that I've seen. The mother's crying, the patient's demonstrating pain, and that's very persuasive, 2 against 1. I call this the city mouse and the country mouse. This is patients who will go into the emergency room. These patients are drug seeking on their way to being addicted to opioids, and they'll say, "I'm allergic to all pain remedies except for intravenous dilaudid push with a Benadryl chaser." And everybody knows that intravenous dilaudid is an immediate high for those who are addicted. Then there's the country mouse. I've seen these patients frequently. They come in and they kind of pretend like they don't know anything about medications. They say, "My friend's on a medication, something like Oxy or Uxy." The doctor wants to be helpful and says, "OxyContin." That's it, doctor," and they write the prescription. Very common for these patients to describe losing their medications. Water's a common theme here. They fell in the toilet. I lost them in the bottom of my fishing boat. They went through the rinse cycle. Calling in on weekends and evenings is notorious in academic medical centers because they know it's the poor intern or the resident on call at night who doesn't have the time to deal with why they might need that prescription, so just refills it to be able to be done with that patient and move along. Seeing a mirror image or the twin is also a kind of a diabolical situation for the prescriber. It's when you're seeing another mental health care professional, a nurse or another doctor or someone in the healthcare field, and you just can't imagine that that person who reminds you of yourself might actually be misusing your drugs or seeking drugs in some way. And then, of course, doctor shopping, a term you may have heard. This is where patients go around to multiple prescribers at the same time in order to get the same or a similar prescription. And bullying is probably one of the most effective techniques. These are patients who basically threaten to sue, threaten to call patient relations, threaten to call their local newspaper because you have not adequately treated their pain. So let's talk about for a moment this behavior. What motivates this kind of behavior? Typically in medicine, we have called this malingering, and by malingering we mean lying or feigning illness for secondary gain. Secondary gain in this case being pills. But I don't think that malingering adequately captures the phenomenon that we are trying to describe here. What really captures it is addiction. And addiction is a phenomenon whereby the frontal lobe, or your decision-making areas of your brain, your willful choice, gets hijacked by the lower brainstem areas. that are driven by the compulsive need to continue to take substances. So I want to talk a little bit about what happens from a neuroscientific point of view in the brain that's driving drug-seeking behavior. And in order to do that, I want you to imagine that the way that you register pain and pleasure in your brain is your dopaminergic limbic system. So dopamine is a neurotransmitter that allows you to experience pleasure. So imagine that this brain network consists of a balance on a fulcrum. And when that balance is tipped to the left, you experience pleasure. And when it's tipped to the right, you experience pain, okay? So tonight for dinner, I went over to McDonald's and I had a delicious small fry. And I haven't had McDonald's fries in a long time. And let me tell you, they were good. So when I ate that first fry, what happened? I had a nice surge of dopamine in my extracellular synapse, right? And my balance tipped to the left. And it felt great. But here's the thing about that pleasure-pain balance. It doesn't want to stay out of equilibrium. It always wants to be level. So once I get that tip to the left, and I have a dopamine surge because of that French fry, my brain is going to respond to that phenomenon in order to bring the balance level again. Now, I think of that in my brain as a bunch of little gremlins hopping on the other side in order to bring the balance level. So just imagine that for a moment. And the gremlins are, of course, metaphor for down-regulating my own dopamine receptors, down-regulating my own, the dopamine that my brain makes in order to bring it balance again. Now, when the brain is balanced, the gremlins hop off and everybody's happy. And what happens if I have another French fry right away? Well, I get a little bit of tip, but guess what? The gremlins are ready for me because those gremlins never go away. So I don't get very far on this dopamine happiness scale, and the gremlins have popped up again, bringing me level, okay? Keep that image in your brain as we now go from McDonald's French fries, which, by the way, are a potent dopamine stimulus, to something like cocaine or OxyContin or heroin or whatever, alcohol, whatever you want to think. The thing about addictive drugs is you don't get a little bit of dopamine, you get a whole lot of dopamine. So when I take Vicodin, I get a huge tip to the left in my pleasure-pain balance. So when those gremlins have to hop on board to bring me back into equilibrium, I need a lot of gremlins to do that, to bring me back up again. The other thing is the gremlins are slow. They're pretty slow. So even when the Vicodin has worn off, the gremlins are still there. And what happens? I start to tip to the right. And remember we said when you tip to the right, you experience pain. And that's what we call withdrawal, okay? Now eventually the gremlins get off and I'm level again. I've reachieved homeostasis. But now you need to consider the condition in which I'm taking Vicodin every single day. So I take my Vicodin, it tips to the left. I take some more Vicodin, it tips to the left. The gremlins come on board and they try to bring me back into equilibrium, but I don't like the way that feels when I start to tip to the right. So I take some more Vicodin and on it goes. Days, weeks, months, years. By the end, I've got a lot of gremlins on this side, right? And they're working very hard to bring me into equilibrium. I'm taking more and more Vicodin because remember, I want to be balanced there. Now one day I can't get any more Vicodin, or maybe I decide I need to stop. This has gotten out of control. So I don't take the Vicodin. What happens? No weight on this side. Boop! I'm over here and I'm in excruciating pain. I'm in acute withdrawal, but I'm also in sustained psychological pain, irritability, insomnia, anxiety, dysphoria. The gremlins are slow, so they're not going to get off right away. So now I need Vicodin just to barely feel normal. And if I don't get it, I'm walking around like this. And that is what George Koob, who has done a lot of the work in the neuroscience in this area, calls dysphoria-driven relapse. And that kind of dysphoria, by walking around like this, is what drives this drug-seeking behavior. Nora Volkow, who's the head of NIDA, the National Institute for Drug Abuse, likened it to this. Imagine that you were starving and that your kids were starving, and you would do pretty much anything to get food, and you would probably go outside your moral compass in order to get food. That's very much what happens when people become addicted to prescription drugs. They're in a state of intense pain, and they lie and they manipulate their doctors, in order to get the drug that they need and want. But it's not because they're bad people, it's because they're addicted. Okay, so we've talked about the drug-seeking patient and what motivates them and some of the neuroscience behind that. Now let's talk about the compassionate doctor. Who is the compassionate doctor? And what motivates the compassionate doctor? In general, people who go into medicine are people who like to please other people. They are also people who have figured out how to navigate the complex maze of the educational system to end up at the top of their class so they can get into medical school. So these are people who know how to navigate systems and they know how to please other people. They're also people who are responding to a higher calling, right? They could go into business, they could go into law, they could go to any number of professions, but they choose medicine because they want to save lives and alleviate suffering. As they go through medical school, they're heavily socialized to empathize with their patients and believe their patients. This is drummed into them again and again. There's no training in medical school for how to deal with patients who might be manipulating you or lying to you or telling you a story that doesn't actually fit with reality. So what motivates the average doctor on the front lines of seeing patients? I'll tell you what motivates them because it motivates me too. It's mutually affectionate relationships with our patients. It's that moment when we feel that we've really helped that individual, when the patient expresses gratitude, when we feel like there's mutual caring, respect, and trust. And even with all the craziness in medicine today, the reason that I get up in the morning and get excited to go to work is because I want to have that kind of interaction with my patient. And even one of those in a day of seeing many patients really sustains me through the day. I think Martin Buber put it very well. When we reach that peak interaction that we want and need as healers with our patients, that our patients want and need, we have what Martin Buber called an I and thou experience. And I'm just going to read this quote. Man wishes to be confirmed in his being by man and wishes to have a presence in the being of the other. Secretly and bashfully, he watches for a yes, which allows him to be and which can come to him only from one human person to another. And I really believe that. I believe that when you can have that kind of intense connection between doctor and patient, healing occurs independent of anything else that's happened. So now we need to ask ourselves, what happens when the drug-seeking patient and the compassionate doctor meet? Basically, they're presented with a conundrum. If I, as the compassionate doctor, question my patient, then I'm at odds with this mutually affectionate relationship. I'm potentially threatening it. But if I don't question my patient who may be misusing a drug I'm prescribing, then I'm potentially a de facto drug dealer. And the result is that doctors are caught between a prescription and a hard place. Do they threaten the mutually affectionate relationship, or do they just let it go? And is it possible to do both? And so what happens is that drug-seeking patients make doctors extremely anxious. And when doctors get anxious, just like when everybody else gets anxious, what do? We call on our primitive defense mechanisms. And defense mechanisms is a psychoanalytic concept from Freud that talks about what we do unconsciously as opposed to a coping strategy, which is something we do consciously. But a defense mechanism is something we do unconsciously when we cannot tolerate our feelings or our current reality. So for example, if I'm feeling anxious, then I may call on a defense mechanism in order to decrease my anxiety in the moment, but I will do it unconsciously. I won't know that it's happening. So a very common defense mechanism is denial, where I just simply deny that reality is happening. And by denying that reality, I don't have to deal with it. Another common defense mechanism is projection. Projection means that I take my uncomfortable feelings, my rage, my sadness, my anxiety, and I project it onto another human being, and that way I don't have to deal with it. So I'm not angry, you're angry. Splitting is where we divide people into good people and bad people because we can't tolerate the ambiguity of a person being both good and bad. This happens between drug-seeking patients and compassionate doctors when they lump the drug-seeking patient into my bad patient category as opposed to my good patients or my real patients. And then passive aggression is a very common defense mechanism, most commonly manifests as procrastination. Doctors commonly do this with drug-seeking patients by canceling their appointment, delaying on rounding with them, spending as little time as possible with them. So now what happens when the compassionate doctor and the drug-seeking patient meet? Let's take a look. Well, this is great. We talked about your diabetes, we talked about your hypertension, I put in the referral for the nutritionist, and you're doing great. So I will see you next time.
Gosh,
okay?
you know, you are so good, doctor. Thank you so much.
My pleasure.
I just love working with you. You know, you're so much better than my old doctor. You take time to explain everything to me. I really appreciate that. I filled out one of those surveys out of the front desk. They give you the patient evaluation thing, you know. I just glowed about you. I just love having you for my doctor. Just one more thing before I go. Could you refill my oxycodone? I know I'm a couple of days early with it, but my family was in town this week, and oh gosh, my fibromyalgia has really been acting up. You know, I think it's probably because of all the extra cooking and cleaning I had to do while the kids were in town. You know.
Okay. Yeah, I'm not sure that's a good idea. I think I just gave you an early refill last month. I mean, I'm not sure. I'd have to check the computer.
No, I don't think so. I don't mean to bother you.
Yeah.
I'm really sorry. I know you're super busy. It's just that my pain has been so bad, you know.
Yeah, I mean, I hear you about the pain. It's just that, you know, you're at really high doses, and we've gone up a lot on the doses, and I'm starting to think, you know, maybe I need to refer you to a pain specialist. And maybe it's kind of, you know, more than I can treat at this point.
Nobody understands. Nobody understands my pain. My husband doesn't understand. My kids don't understand. I thought you were the one person who understood. I thought I had one person that cared. I wish you could spend just one day in my skin. 1 hour in my skin, you would understand how unbearable this pain is. Now I see you don't even get it. You're just trying to get rid of me, push me off on some other doctor and abandon me.
Okay. I'm not trying to. I'm not trying to abandon you. I care about you. I care about your pain. Okay, I will write you an early refill this time. Okay. But this is it, okay? This is the last time. Please just take it as prescribed.
I will, doctor, I will. I promise I will.
Because I'm not going to do any more early refills, all right? This is it.
I understand. It's just that with my family in town and the holidays and all the stress of that's all it was.
Okay.
I'm sorry I broke down like that. I know you care about me.
Okay.
I know you really do. You've always been great.
All right. Okay.
So, I just said those things because I was scared. I'm sorry.
No, that's okay.
Sorry.
No, that's okay. I understand. Okay, so really nice to see you, and I'll see you next time.
All right,
okay?
thank you.
Yeah,
Thanks a lot.
You're welcome. All right, take care.
Thanks, you too.
All right, bye-bye.
Bye-bye.
Okay, so the point really of this video is that is not good care. This is a patient who has a legitimate pain condition, who needs help for her pain, is on her way to possibly overusing, misusing, or getting addicted to her prescription opioids. The doctor should really investigate further what's going on here, but instead just prescribes another early refill, and then when the patient leaves, rolls her eyes and she's exasperated with the patient, which is a kind of projection, right? Instead of looking at yourself and saying, wow, I'm somehow not managing this properly. I have a sense that things are out of control with the pain meds. And this is happening in exam rooms around the country. When I give this talk to physicians, there's this incredible sort of catharsis in the room because so many doctors can relate to this kind of scenario and feel a lot of shame about it, actually, because they know it's not good care, and yet they find themselves engaging in this kind of scenario again and again. So the question then, and you know, there were primitive defense mechanisms at work. I talked about projection. There was a certain level of denial. There was splitting. But what happens when the doctor's primitive defense mechanisms no longer work? For example, we have something called a prescription drug monitoring database where you can go in and see all of the prescriptions for controlled drugs the patient has received in the past year in the state of California. And that's a way to find out whether that's one of the ways to potentially find out whether your patient is overusing a medication or going to other doctors. So if a doctor goes on there and makes the effort to go on there, it's somewhat effortful because you have to get an access code and you have to take the time to do it. And you find out that in fact this patient is way overusing the medicine, using unsafe combinations of medications, then essentially you realize, oh my gosh, I've been giving a medication to a patient who's been misusing them. So what happens in that scenario? Basically what happens is the doctor experiences what we call a narcissistic injury. And that is not to say that all doctors are pathological narcissists, not at all. Basically, any of us can experience a narcissistic injury when we have a threat to our sense of competence. So when a doctor feels that somehow that patient has been injured by them because they overprescribed a medication and didn't know the patient was misusing it, that's an injury to that doctor's sense of competence as a healer, and that's a kind of a narcissistic injury. As I was just talking about, there's healthy narcissism, which anybody has when they invest their creative energies into being good at something. Anything that you invest your energies into being good at, if you then have an experience where you feel your competence is threatened, you will experience a narcissistic injury. And it may not even happen on a conscious level. But when you do, the most common reaction is narcissistic rage and retaliation, typically toward the person who made you feel incompetent. And so let's see what happens when that happens.
Just one more thing before I go. Could you refill my oxycodone? I know I'm a couple of days early with it, but my family was in town this week, and oh gosh, my fibromyalgia has really been acting up.
Okay, I'm not too comfortable with that, but I'll tell you what, I just got access to a brand new database that allows me to look at all the prescriptions that you've received in the last 12 months in the state of California. So let me just look your name up on that, and that will kind of help me be able to make a decision about whether or not it makes sense to do more pain meds. Okay, so just give me one second.
Is that something that you can do after I'm gone? I really kind of need to get back to.
No, let's take the time. I think it's worth it to take the time now. Oh wow, wow! I'm surprised. It looks like you've been to see a couple of other doctors to get more opioids, and there's some benzodiazepines, clonazepam, and
yeah, I can explain that. I have a tooth abscess. I went to see my dentist this week, so
okay.
There was
this Dr. Smith. I mean, who's the Dr. Smith?
Oh, Dr. Smith is my OB-GYN. I've been going to her for years, and it was just time for my pap smear. So I just had I had several people I had to see this week, but of course you're the person I count on.
Okay. And who's this Dr. Williams here? And there's a Dr. Jones. I mean, seems like a lot of meds going on. They're the same ones I'm prescribing.
Well, I have a medical condition that involves pain, so this pain medicine is obviously something that I need in order to manage the condition. I don't know why I feel like I have to defend myself about this.
Okay, well, I'm sorry, but I'm not going to be able to prescribe opioids anymore for you. I mean, you're obviously addicted, and I'm not going to be able to. I don't think I can actually treat you anymore. I'm going to have to ask you to leave.
I'm not addicted. I mean, it's not like a drug addiction or an alcoholic or something. This is a medical condition. I'm getting pain medication for a medical condition. I thought I could count on you to help me out with this. This is the only medicines that help with my pain.
I'm sorry, but it is clear, I had no idea that this was going on. Had I had any idea, I would not have prescribed the way I've been prescribing. So I'm sorry, I can't treat you anymore. You betrayed my trust. You broke the pain contract. I'm sorry, you're going to have to leave.
Aren't you a person who's supposed to help take care of someone with a medical condition?
I'm going to have to ask you to leave now. Okay, I have my next patient waiting. Thank you. Okay, so another example of very poor care in the opposite extreme, and this also has been happening all around the country, doctors who suddenly realize that their patient has been misusing medications in one way or another or has become addicted. And instead of trying to help that patient, I mean, it's very poignant, actually, this patient saying, aren't you someone who's supposed to help someone with a medical condition? Instead, they reject these patients and turn them away. And it goes without saying that this doesn't solve the problem. And in fact, probably creates new ones. Dr. Stephen Pasek has coined this phrase, opioid refugees, where he talks about patients who were put on opioids in very high doses by their doctors, maintained on those opioids for decades, and then suddenly told, I'm not going to prescribe for you anymore. And we talked about the pleasure-pain balance, this process of the neuroadaptation and the gremlins. When someone has that kind of physiologic adaptation to opioids, they can't come off of them in a day, and they can't even come off of them in a week. It takes months, if not years, to help a person like that come down and off of opioids. And yet that's not what we've been doing with many of these patients. Heroin overdose deaths are on the rise, as is heroin use. And there is some speculation that some of the increase in heroin use may be related to the fact that patients who became dependent and or addicted to prescription opioids and could no longer get them then turned to heroin. So the real question is, how can we do better by our patients and also by our doctors? Importantly, don't do this. Don't retaliate against these patients and fire them from your practice. Instead, we need to educate doctors on how to screen and intervene for addiction and get them to recognize it as a chronic, relapsing, and remitting disease. Put it on the problem list and get your patients treatment for it. Treatment for addiction works when patients actively engage in treatment. We also need to pay for addiction treatment. The Mental Health Parity and Addictions Equity Act of 2008 mandated that we reimburse treatment for addictive disorders on par with other major medical illnesses. Nonetheless, insurance companies continue to find ways around this mandate. So many of my patients who want and need help for an addictive disorder can't get their insurance companies to pay for it. We also need to get insurance companies to pay for non-opioid alternatives to chronic pain. So, okay, now we know opioids long-term probably do more harm than good, but we can't just take them away without offering something else to our patients. There are lots of other things that work that the medical community could offer, from acupuncture to physical therapy to trigger point massage to psychotherapy, having our patients learn meditation and other practices to tolerate their pain. We also need, I think, on a larger systemic level to move toward value-based care and away from fee-for-service. Most of our country is dominated by fee-for-service medicine, which means the more procedures, pills, and operations a doctor does, the more he or she gets paid for it. Today, that means that the individual doctor doesn't get paid, but the large integrated healthcare system gets paid. So there is no incentive to actually get patients well or to make them better, because the sicker they stay, the more money the healthcare industry makes. If we go toward value-based care, and we are now trying to move toward that, that means that integrated healthcare systems and doctors will be reimbursed for whether or not their patients get better, not just what kinds of procedures are offered. We also need to regulate Big Pharma. I didn't talk about this much today, but I talk about it a lot in my book. The interconnectedness of the pharmaceutical and medical device industry and medicine in this country is abominable and shameful and does not lead to improved care for our patients. And we need to do a much better job regulating that. I'm going to close with a quote from Reinhold Niebuhr. He says, quote, "Ultimately, evil is done not so much by evil people, but by good people who do not know themselves and who do not probe deeply." And I think that's what happened with the opioid epidemic. Even as we were vaguely and unconsciously aware of it happening around us, we didn't want to look too deeply because there were so many incentives to just keep prescribing. I hope that will change. If any of you is interested in using these videos for teaching purposes or other purposes, they're available online. And thank you for listening. I'd be very happy to take your questions. Yes?
Does opioid mean addictive?
The question is, does opioid mean addictive? No, opioids are a certain type of drug that are derived from the opium poppy. And there are many different kinds of opioids. There are naturally occurring opioids like opium and morphine. And then there are semi-synthetic opioids where you take something like morphine, put 2 acetyl groups on it, and you get diacetylated morphine, and that's heroin. And then there are fully synthetic opioids that are entirely made in the laboratory. A lot of the opioids that that are prescribed now, from fentanyl to OxyContin, are fully synthetic. So opioid is a type of drug that is highly addictive, but opioid doesn't itself mean addictive. Yes?
When you refer to centers to treat care, do you look at clinical efficacy of those treatment centers? How do you, is there any smart direction of care currently occurring, or is that just kind of a blind into the ether of opioid care?
Right, so are you talking about addiction treatment centers?
Addiction treatment
Okay,
centers, yeah, exactly.
so the question is, how do I think about where to refer patients who need help for addiction? Do I look at their treatment methods and whether it's evidence-based, or what kind of algorithm do I use? And the answer is, wouldn't it be wonderful if I could base my referring on that? But there are 2 major obstacles to that. One of them is there actually isn't a lot of evidence on a lot of the methods that are used in these treatment centers, especially residential treatment centers. That's not to say that they don't work, but the evidence is not robust, meaning to say there aren't enough studies out there. We need more science in this area. But more importantly, even if there were the science, I wouldn't have the luxury of referring that way, because I'm reduced to referring to whatever the insurance company will pay for, and they will pay for very little. So oftentimes, when we teach physicians about addiction treatment, we always talk about overcoming denial and, getting the patient, motivated to seek treatment. I'll tell you what I see is a lot of patients who are not in denial at all. They're desperate for help, and they can't get help because it doesn't exist, and/or their insurance company won't pay for it. For example, there are some wonderful treatment centers all around the Bay Area, residential treatment centers that cost upwards of $75,000 a month. Very few members of our society can actually afford that. I will give a big shout out to Kaiser, which I think has one of the most progressive and best models for addiction treatment today. Of course, they have a population health approach, so already right there, they're doing things right by basing their treatment interventions on health outcomes. But they have a wonderful program called the Chemical Dependency Recovery Program, and it's like a one-stop shopping. You can walk in and say, I'm intoxicated, or I'm in withdrawal and I need help, I want to stop. And they've got it all right there with a multidisciplinary treatment team. They do a great job. I wish that we could all move toward that kind of model.
Thank you.
You're welcome. Yeah.
So are there effective psychotherapeutic treatments, some more effective than others?
The question is, are there effective psychotherapeutic treatments, some more effective than others? What we know about psychotherapy for addictive disorders is that it works. There probably is not a big difference between what type of therapy per se is being used. What tends to be efficacious in any kind of therapy, psychotherapy for any kind of mental disorder, is some intangibles, like how well you connect with that individual, how much you trust them.
Sorry, I meant for pain control.
For pain control. Okay, good. So same thing with pain control, that, basically the intangibles of the connection between you and the therapist are probably more important than any particular type of psychotherapy. Having said that, there is a big push now toward things like mindfulness meditation, which basically, in a nutshell, what is mindfulness? Mindfulness means learning how to be aware in the moment of your thoughts and feelings without judging it. And by being aware in the moment of your thoughts and feelings without negatively judging yourself for having those thoughts and feelings, you can then begin to modulate your behavior to adjust those thoughts and feelings to improve your comfort. And once, of course, you improve your comfort, your anxiety, your depression, that's intimately connected with better tolerating your pain. So there are a lot of people with serious pain conditions, and it's not a magic solution, but we know that the brain is interconnected in a way around emotions. So if you can learn to regulate your emotions, it's very helpful. The other type of psychotherapy that's very helpful for pain and addiction is something called DBT, or dialectical behavioral therapy. Dialectical behavioral therapy teaches specific skills to help grapple with pain. So, for example, one might be distraction. If you're feeling consumed by your pain, try to get absorbed in something else. So instead of having your blood flow go to your pain centers, you want to pull your blood flow to other centers of your brain, your frontal lobe, and focus on something else. It may only work for a while. When you're done focusing, you may again be in that state of pain, but it can have a powerful easing effect in the moment. Another dialectical behavioral therapy technique is something called opposite action, where you do the opposite of how you're feeling. So even though you're feeling like you're too tired or in too much pain, to take that next step, to go to a movie or go see a friend, you make yourself, or exercise, you make yourself do it anyway. So there are little tricks like that. Yes?
The doctor that we saw obviously made 2 mistakes.
Yeah.
Assuming you were in that position, what would you say to her to send her out feeling neither overjoyed that she got it, or that you sent her out?
Yeah.
What could you?
Yeah, so great question. So those videos were examples of what not to do. The question is, what should a doctor do? And if I had had time and resources, I would have made those follow-up videos. So, but basically, in the first scenario, what the doctor should have done was communicate to the patient, I'm concerned that in addition to your pain, which I want to help you with, that we may be developing another problem. And what I do a lot in that scenario is I really normalize the addiction that can occur. I said, when we first started prescribing opioids for pain 20 years ago, when we started prescribing them long term, we didn't realize how addicted they would be for people. But now we realize it can happen, and you're not alone. But since I'm very concerned that this is happening, I think I need to follow you more closely. And we really need to track how you're taking this, and even possibly consider coming down and off the opioid. Because in many instances, what we find is when we do that and people are able to get off the opioids, their pain actually gets better. So being on chronic opioids can cause this, what's called opioid-induced hyperalgesia. Algesia means pain. People can have hypersensitivity to pain when they've been on opioids long term. In the second scenario, that was more a case where there was evidence that the patient had become addicted. She was going around him, she was kind of lying. It was more obvious. Then the doctor can remain in a compassionate stance, and that's the key thing, not just for the patient, but for the doctor's her own sense of competence, right? As a healer, remain in a compassionate stance and say, again, I think what this shows me is that we need to be concerned that you've developed an addiction. Here's the good news. There's treatment for addiction. There's really good treatment for opioid addiction. So we need to work together to figure out if that maybe is possibly going on here, and if it is, we need to get you into treatment. Yes?
Yes, I would like a response to the suggestion that what we really need to do is learn how to manage addiction rather than eliminate it. Because you spoke of people who had addiction that lasted several decades. So what's the matter with that? Now, the voters of California, in their infinite wisdom, have legalized marijuana because everybody believes that marijuana does not produce addiction. But you, as a professor of psychiatry, know that it has many instances where it produces serious behavior modification. Okay? Behavior modification is okay. Addiction isn't okay. So what's your response?
Okay, so I think it's hard for me to repeat your question because I need to clarify language with you first. So when I use the term addiction, I'm talking about a complex biological, psychological, and social phenomenon. That's different from dependence. Dependence is the purely physiologic phenomenon that can happen with somebody who's been on opioids for decades, and they're not necessarily the same thing. Most people who become addicted are also physiologically dependent, but some people who become physiologically dependent are not actually addicted. These are people who are taking it as exactly as prescribed and never engaged in the kind of compulsive, out of control behavior that we associate with addiction. So were you talking about addiction or dependence, or maybe you could rephrase your question, because I think I know what you mean, but I don't want to assume.
I'll give you an anecdote of the case, okay? I knew a guy 40 years ago when marijuana was just becoming very popular with the Beat Generation and everything else. He was the heaviest user of marijuana I knew. Okay? His behavior, his attitude completely changed. He was fired from his job, and he eventually pulled himself together and became one of the strongest anti-marijuana persons I've ever seen. Okay? He was not dependent chemically. He was not addicted chemically, but it changed his behavior.
Okay, so
And I've heard of many cases like
yes.
this.
Okay, so I would say, based on that anecdote of someone who used marijuana so heavily that it destroyed many aspects of his life. Did I understand that correctly?
Yes,
So to me,
he didn't have proper motivation.
right, he wasn't motivated. It interfered with his ability to perform in his job. So that is what we call addiction. We call that addiction.
But it's not. He had no chemical dependency at all. When he
Yeah.
decided to stop, he stopped without
Right.
any withdrawal
Right.
symptoms.
Yeah, so this is a great teaching moment. Thank you so much, because the point that you're making is that because he wasn't physiologically dependent, he wasn't addicted. But as it turns out, you don't need to be physiologically dependent to meet criteria for an addictive disorder. If you have, so how do we define somebody who's become addicted? Basically, you have to think of the 3 C's: control, compulsion, and consequences. People who are addicted are people who have lost control of their own use. Someone who said, I was just going to drink a couple of beers, and 12 beers later, okay? Compulsive use. This is people who spend an enormous amount of their mental real estate thinking about obtaining the substance, using the substance, recovering from the substance, lying about the substance. That's compulsion. The 3rd C is consequences. People who have serious consequences due to their use. That can be consequences at their job, consequences in their meaningful relationships, legal consequences like getting a DUI. That's the 3rd C, especially if there is continued use despite those consequences. So that's how we define addiction, and based on that very brief anecdote, it sounds like your friend was addicted because of the serious consequences that he had. But I agree with you, the first thing you said, that we need to learn to manage addiction. We need to conceptualize it as a medical disorder, and we need to treat it, and we need to get the healthcare industry to pay for that treatment. Yes?
Could you say a little about geographic distribution of addiction in the US, and what are the causes of those differences?
Well, one thing about addiction is that it crosses all racial, ethnic, and socioeconomic barriers, and that's one thing that's very powerful about it. There are certainly regional differences in the types of substances that people will use. So, for example, at various points in history, for example, crack cocaine was an inner city problem. The opioid epidemic, although nationally very widespread, has been associated with middle class as well as poor Appalachian phenomenon. So there are regional differences because it can be a social network disease, right? Who you know, what they're using, you use that too. There was an interesting study that looked at regional differences in the use in prescribing of opioids in this country, and found that it was not at all linked to the need for pain relief or analgesia based on medical conditions. It was linked to the number of doctors practicing in that area. So what that tells you is that you've got mainly the number of doctors, doing business, driving the number of opioid prescriptions, not the need for those opioid prescriptions. But to me, one of the most interesting things about addiction is how it is this complex biological, psychological, and social disease, and it really does depend on context. Last year I went to China and I interviewed patients who were seeking help for heroin addiction. And one of the most interesting things about my interviews was that when I talk to heroin addicts in this country, typically they will tell you they started with alcohol, progressed to cannabis, and then X, Y, and Z other drugs, and then eventually got to heroin. Or the new story is I got a prescription for an opioid, and then I got to heroin. And then first I was smoking it, then I was snorting it, and only at the very last was I injecting it. So that's a typical trajectory. In China, the very first exposure to any drug can be intravenous heroin, or chasing the dragon, which is a way of insufflating heroin. So these regional differences are, and that's because of the vestiges of the Opium War and the ubiquity and the access to heroin in China, as opposed to prescription opioids, which they cannot get at all, except that if it's tramadol, they can go into any kind of drugstore and get tramadol over the counter. Tramadol is also an opioid. Yes?
Why do general doctors know so little about these medications, their side effects, their withdrawal symptoms? Because we need to teach them too.
Yeah, I mean, I couldn't agree with you more. The question is, why do general doctors know so little about these medications, their dangers, their side effects? This is a huge hole in medical education, which I am working with others to remedy. But you're absolutely right. I have had more patients come to me in the last year on high-dose benzodiazepines like Xanax, Valium, Klonopin, started by their family doctor, not told anything about the addictive potential, people with no history of addiction, and now they're terribly physiologically dependent, if not addicted to these medications. So you're absolutely right. This is a huge, huge problem. Doctors are very poorly trained in this area. We need to totally revamp medical education, and from the first day of medical school, teach them about addiction, teach them it's a disease, talk about the chronic relapsing and remitting nature of the disease, and specifically teach them about the risks of the medications that they're prescribing, because if they become, the source of these medications, they really better know what they're getting into, and they better educate their patients about those risks. I really agree with you. Yes?
I read an article that said the U.S. has 4% of the world's population, but 80% of the opioid use. Why can't we just do what the other countries do, ban it? I mean, do we really have to have it? There's drugs that are not quite as good, but okay. Why don't we just ban opioids?
So the comment in question was that the world over, the United States consumes something like 80 to 90% of all prescription opioids in the world. So this is a really shocking and horrific statistic. And then the question was, why don't we just stop? Why can't we just stop using them? What my book gets at is why it's so hard to stop. What are some of the driving factors? Some of it is patient-driven, some of it is doctor-driven, much of it is industry-driven, much of it is driven by the system that we have today. There are also cultural pieces. We live in a time and place when we really are not, our expectation is that we will be pain-free. And even further than that, there's a lot of fear about experiencing pain because we associate pain with future pain. It wasn't always that way culturally. Culturally, 100 years ago, there was considered to be some value in it having a painful experience. What doesn't kill you makes you stronger. We've really shifted the other way. All kinds of pain is associated now with leading to more pain, whether it's a psychic pain or a physical pain. So there are cultural pieces. I do want to add that, though, one of the big problems globally is although we have too much access to prescription opioids, there are many countries in this world who have almost no access to prescription opioids and really are in desperate need of minimal access to things like morphine. People who are undergoing horrible traumatic injuries and surgeries and horrible end-of-life suffering who have no morphine at all. So we have this, this kind of crazy duality going on. I think that Nora is looming because you want me to end, or can I take a few more questions? Okay. 1 or 2 more questions. All right, good. Yes.
So I'm curious to hear your thoughts on the evolution of the insurance industry's response to this crisis, and more specifically, why hasn't this bubbled up to the surface of something that's right at the top of their radar issues to solve?
I wish I knew the answer to that question. It's a great question because it's not merely that insurance companies won't pay for complex chronic diseases. They will pay for renal dialysis. They will pay quite easily for gender identity sex change operations. They will pay for all kinds of serious chronic conditions from diabetes to heart disease to asthma. They won't pay for addiction treatment. And I think that has to do with, again, a kind of enduring misconception that it's not treatable, that no matter, how much money you pour into it, people won't get better, which is not true. People do get better when they have access to treatment and actively engage. So it's a bit of a mystery to me. I haven't quite figured it out. Another piece of it is also that it's a huge industrial medical complex. And if you have a disorder that requires talk therapy, physical therapy, meditation, acupuncture, there's no medical industry behind that, right? There's no pills, there's no devices, there's none of that going on. But if you have a disorder that requires a renal dialysis machine or requires a surgery or requires lots of expensive chemotherapy, then you've got a whole other set of people who make a lot of money on that. And so that I believe is probably what is driving that. Yes?
How does one find the right treatment center for addiction without having to talk to many different doctors?
Well, what I recommend is that you go and see an addiction medicine specialist if you have access and try to see what that individual recommends, because they usually have a pretty good sense of the local treatment centers and can tell you the pros and cons. But honestly, I'm going to say from a purely practical point of view is that you see what your insurance company will pay for and then you explore those treatment options. In general, it's best if you can go to a treatment center that actually has a medicalized treatment, so there are some doctors on site. There are some treatment centers that don't have any doctors affiliated with them. It's all peer recovery. I really believe in peer recovery. I think it's a great asset, but it's good to have doctors and or nurses on site who can do the medical part. I'm going to take one more question because I didn't want to let you go.
Oh,
Yeah.
Thank you.
Yeah.
I had a quick question there. With all the scrutiny and all the heavy monitoring and the regulation with the FDA, they're paying doctors. I'm talking about myself personally, I go to a paying doctor there. Have you noticed that there's been a reduction as far as actually being under-medicated? With doctors there being a little bit gun-shy with all the heavy-duty scrutiny that's going on with the FDA there? Because that's what I find personally what's going on with me there. I have 35 years of chronic cervical pain that I'm actually due for a surgery. And I've got on board with a doctor right now, but I mean, I'm totally under-medicated. I mean, I'm probably shy, I'm within a distance of it as far as not even becoming probably addicted or anything like that, but I mean, I'm really not even in the same ballpark where I should be prescribed medication. And I was just wondering if you think there with the doctors being heavily monitored and regulated there, that they're not even prescribing maybe with what your condition warrants.
Right, so the question is, is there a concern that now patients with pain are being under-medicated? And that was kind of what I was trying to get at a little bit with the second video, that there's been this retaliation against patients with pain, which is not helpful to them either. Although in general, we don't believe that chronic opioids are effective long-term for pain. If a patient has been taking chronic opioids long-term, it is the responsibility of the doctor to help them come off of opioids and to do that in a compassionate and slow way, as well as to provide them non-opioid alternatives. You can't just take away the opioids and not give anything else. You've got to provide some kind of alternative. I think I'm going to go ahead and close there. Thank you so much for being such a great audience.
Thank you.